Hi, everyone. Thanks for joining. We're going to kick off the webinar. So thanks for joining for the Including Caregiver ID initiatives as part of Family Presence and Open Visiting Policies in Ontario Hospitals. This webinar is co-hosted by the Change Foundation and the Ontario Hospital Association. Just a little bit of webinar housekeeping. If you are using the chat box, please feel free to introduce yourself, share your social handles, and use the chat box to ask any questions and contribute throughout the session. If you run into any technical issues, please use the raise hand icon. It's most likely hidden as the More button, and then you'll be able to reach our technical support. And throughout the webinar, feel free to share your Twitter handle and give the Change Foundation and Ontario Hospital Association a follow. And please remember that if you are using the chat, have it set to all panelists and attendees so everyone can see the messages coming through. And with no further ado, I'm going to turn it over to Kathy Fuchs, who's the President and CEO of the Change Foundation.
So good afternoon, everyone, and let me add my welcome to all of you. We're very excited to be able to present this work to you today. It's been a long time coming, and we're very pleased with the results and the interest in the webinar today. With me today, in terms of the speakers on the agenda, I have Lori Hale, who is Executive Lead for Research and Policy at the Change Foundation, who's going to talk a little bit about the research study that we did. And there's Christa Haanstra, who is the Executive Lead for Strategic Communications and is also our lead on young carers. And she led the development, along with our Changing Care partners, of the Caregiver ID, which we're going to demonstrate for you today. And then lastly, but certainly not least, is Jennifer Ridgway, who is the program lead for our Changing Care team at the Sinai Health System and Wood Green Community Services partnership. And she'll get into the real nitty-gritty of, if you're interested in doing this, how to do it well, and what to expect. I do want to start, though, with our land acknowledgement, which is there up on the screen, which you can read at your leisure. It's just something that we want to recognize and honor before we start into the conversation today. Our agenda then, we're going to start with the research study, so you can see the results of the survey that hopefully some of you, as well as others, participated in, where we were just trying to get a handle on what's current practice and what are the issues that people deal with when they're trying to implement a change in policy to family presence. Then we'll get into the Caregiver ID initiative, which was developed separate from the family presence work, but it obviously was a fit in terms of discussing implementation. And then we'll talk about the how, what organizations can do to roll this out in a way that doesn't confuse everybody. And then we'll hopefully have some time at the end for some questions. When we asked you to register, we did throw a couple of questions at you because we were just interested in who was actually joining and why, and these were sort of the top responses. People wanted to understand more about the research project and the actual results. Another set of people were very interested in the implementation of the ID initiative, and there was a third group that people were in a working environment that didn't have a family presence policy, but were interested in implementing one. The partnership is very much one between the Change Foundation and the Ontario Hospital Association for fairly obvious reasons. The topics align nicely, but also because the Hospital Association actually established the Change Foundation almost 25 years ago, so we have a long history of working together. And I do want to recognize Andrew McLeod, who is not actually speaking today, but is a staff member at the OHA and was very much a partner and did a lot of the work, both in recruiting hospitals and also in interviewing. The other reason that this is sort of an interesting time to be looking at this work is, given all of the health reforms that are being proposed in Ontario, and specifically Ontario health teams, there's a lot of language around patient and family engagement and experience, and certainly looking at a commitment to family presence and caregiver ID would support those sorts of policy directions. So I'm going to turn it over to Lori now, who will take you through the actual research study.
Thanks, Kathy. Okay, just get you. So I wanted to give a little bit of context in terms of why the Change Foundation and the Ontario Hospital Association wanted to pursue this partnership. Early in the Foundation's Changing Care projects, we started exploring Caregiver ID, and it became evident very early that there was a lot of linkage and alignment with the family presence policies. So we reached out to the OHA, and they were interested in finding out what the status was, given that a lot of hospitals were moving in that direction. Through the partnership with the OHA, we saw an opportunity to both promote family presence and Caregiver ID, and really make a positive contribution to health system transformation. I wanted to talk a little bit about the methodology and how we actually pursued the research project. We wanted to do telephone interviews with those people who were directly involved in the development and implementation of the policy. And we worked with Andrew at the OHA to develop a list of hospitals who would participate as part of the research. We wanted a range of experience, so we have hospitals that have long-term experience with family presence, as well as those that have shorter experience, under 5 years. We have large urban academic hospitals, as well as small rural and remote community hospitals. We also had in the sample 2 pediatric hospitals and 2 mental health hospitals, and we required that for confidentiality purposes. So in terms of the what, I'm going to, in the next few slides, just give you an overview of what we learned in conducting those interviews with the 13 participating hospitals. So some of the highlights, a lot of variability in the policies across the 13 hospitals. Some made distinctions between visitors and care partners. Some avoided the term visitors. Some hospitals had a requirement that the person actually be able to provide care and support. Some hospitals had designated quiet hours, so that those that weren't the designated care partner would actually leave at when the designated quiet hours were in place. The other thing that was a highlight was the significant role that patients and families had in instigating or catalyzing the move to family presence and open visiting. And this was often through the Patient Family Advisory Council or the hospital's patient and family advisors. And they not only played a part in instigating the move, but also were very much a part of the co-design and development of the policy. The shift to family presence policy often formalized what was already happening in place in the hospital. And people were on the units were making accommodation under an environment where there was visiting hours. So when that shift took place, we heard a lot in the interviews from the people we interviewed that this really just put pen to paper, or it confirms practices that we were doing anyway. All hospitals acknowledged that there were pockets of concern during planning and implementation, and that actual challenges did come up during implementation. And those challenges were related to space issues or privacy issues, even practical things like elevators shutting down. And we heard about the importance of having in place a process to better understand what those concerns were, what those actual challenges were, and to address them as they came up. And there were lots of examples of what that process could include. So things like having a point person, having real-time feedback in regular rounds on the unit. And finally, most of the hospitals we spoke to referenced that the family presence policy was part of a culture shift. And that culture shift was towards a more collaborative care planning process where the family member was valued for their role and their expertise was valued as much as the clinical expertise. So just in terms of, what were the changes that patients and families experienced and staff experienced in that shift to a family presence or open visiting policy? For patients, prior to the shift to family presence, the situation was often staff would accommodate them, but once in a while a staff member would point to the visiting hour policy and say, no, visiting hours are in place, you have to leave. So with the shift to the policy, there was a lot more consistency. The shift to family presence also meant that many family members didn't have to worry about getting to the hospital on time if they were juggling work, family life at home, and trying to get to the hospital in time before visiting hours ended. Spending time at the bedside for family members actually gave them a chance to see the high level of care and support that their loved one was receiving. So that resulted in increased trust. And finally, for many caregivers, just being able to spend some time with their family member reduced the stress that they were feeling. On the staff side, the shift provided a clear standardized way for them to make decisions. The policy usually, in most cases, included clear guidance on when they could set limits to family presence. And there's lots of anecdotes in the report about what those situations would be, whether it's in terms of family members being sick or infectious or immunocompromised, or in safety situations. So there are a number of stories in the report about what that guidance might look like. The other thing, staff very much felt supported by family members at the bedside. There was concern before the policy was implemented, but once it was implemented, they actually could see how family members were helping out. They were providing another set of eyes, and staff actually recognized that the family member was actually knew the patient best because they spent the majority of time with them. And then finally for staff, with the shift, rather than depending on an established policy of, its end of visiting hours, staff actually needed to draw on a different skill set. And I've noted some of those there in terms of judgment, negotiation, communication with family. Okay. The people we interviewed actually provided a number of pieces of advice. The first one was that you can learn a lot from other organizations who have already implemented the policy, and everyone we interviewed was very complimentary of how open other hospitals were, the early adopters of family presence, how open they were to sharing their successes, their pitfalls, what people should look out for when they're implementing a policy. And I just wanted to add that most of the hospitals that we interviewed in this research project have agreed to serve as mentors to others who are interested. So we certainly will be able to provide that contact information if people are interested in finding out more about family presence and how to actually develop and implement a policy. A key reflection was that people really need to understand why the policy shift is being made. Answering that why question is really critical. The other point that piece of advice was it was really important to involve key influencers and key stakeholders as part of a well thought out change management plan. And there were examples provided on how you would do that, including using unit champions or using peer-to-peer coaches. So maybe one part of the hospital had longer experience with family presence and using them as peer-to-peer coaches to other units who may have unique challenges in implementing the policy. Also, terminology is really important, and thinking carefully about terminology was a piece of recommendation that the people we interviewed had for others. As I mentioned earlier, the term visitor is being phased out by many hospitals. The term care partner is a popular term in many of the policies. Many hospitals refer to the extensive use of scenario planning and providing training and educational resources or tools to help people and staff with any concerns that they may have before the implementation of the policy and during the implementation. And a final piece of advice was to have multiple routes for nurses, physicians, and staff to voice any concerns or any unanticipated situations that may come up. And so there were lots of examples of what those multiple routes might be in the report. The report is loaded with quotes and stories. And I think that's where the richness of the report is. So you'll get a lot of details in terms of what are the components of a change management plan. We also use the quotes and the stories to present useful reflections on the unique circumstances in mental health hospitals and in pediatric hospitals. So if you haven't read the report, I'd encourage you to do so. As I said, it's loaded with the stories and quotes, and I'd encourage you to read it. So with that, I'll hand it over to Christa.
Hi, everyone, and welcome. It looks like we have about 80 organizations and people on the line, which is great. I think there's a broad interest in both the topic of family presence and caregiver ID. As Kathy mentioned at the outset, we didn't create the caregiver ID process with family presence in mind, but immediately when we started working on it, we saw that people were connecting the two. And so we want to talk a little bit about how that can be done today. And very similarly to the family presence policy, there are different ways of looking at and integrating a caregiver identification program within your organization. Ultimately, we see the caregiver ID as a visible way to demonstrate a commitment to caregivers in the organization. And it's very concrete for family caregivers. And it's also a really great complementary component to a family presence policy because it creates that awareness across the organization by simply seeing an identification in whatever form across the organization and throughout the hallways. So what we ultimately created was a visual design for the I Am a Caregiver campaign. And it comes in multiple forms. So there are people who use it as a button or a card or a sticker in some cases. And so there are multiple ways that you can format it, but ultimately we wanted to create a visual ID that was recognizable across the province, we hope, at some point, but ultimately consistent across the organizations who were early adopters. We created this caregiver identification, as Kathy said, as a core component across our 4 changing care partnerships across the province. So that means that we had representatives from each of those different partnerships on the group designing this, as well as a number of family caregivers, because for us, we believe very strongly in co-designing everything we do with caregivers as equal partners around the table. We really believe that caregiver identification can be an important part of family presence, but more importantly, it is a huge contribution to the culture of partnering with caregivers in whatever organization you're working in. And this is a visual that we took from one of our two changing care partnerships that have introduced the ID, and it really speaks strongly to what it means to caregivers to be identified and recognized and given some kind of recognition and card, physical manifestation of that to recognize their role. So I'm actually going to show you a video of a woman who talks about the importance of recognition, because we can talk about it, we can show you the data, but it's never as powerful as hearing from an individual just what it means to be a partner in care. And so I'm going to we're going to listen to Sandi's story for a moment, and then I'll just follow up with a few more key slides on benefits and implementation ideas.
My husband had surgery to do a bone graft for a transplant 6 years ago, and they cut into a nerve. And that's when all the pain started, and that's when all of the drugs, medications started. It really changed our lives because he really couldn't function the way he did before that. And I ended up taking a great deal of responsibility. We had a business, and within a couple of years decided that we would close business and he could retire. He had a triple bypass unexpectedly, and he went back to the hospital 2 weeks later with a septic gallbladder after his stay at UH. We arrived at Parkwood at the day hospital, and he had amazing care. What I found as a caregiver at Parkwood was that the inclusion as a partner in care was there right from the first day. I was so impressed that the staff really meant inclusive, part of the circle of care. It wasn't just come to the meetings because we're going to look after the patient. That so often happens. We are often invisible as caregivers, and yet, if this was theater, the patient's the star, and we're the supportive role. Sometimes people don't realize the incredible fatigue and how overwhelmed it can feel. When you are a support person, you need support. If you're going to shine your light in the world, you have to fill up your lamp. And the only way to really do that is to have the support of others and the encouragement of others. For me, the support came in everybody's greeting, including me in the "How are you today?" A hello can bring a smile as quickly as anything else. And when you get a smile too, with an energetic staff person, you just feel as if you've walked into a hug. I think people go into the healthcare profession because they have incredible compassion. They want to help. And the most important message is use that smile, use the hello, use the names for the care partner as well, so that they get their lamp filled up. They get energy to be able to do what they need to do.
Let's try that one more time. There we go. So I think you can hear from Sandi's story just how important it was for her not to feel invisible. That is a word that we hear a lot from caregivers, and to feel like she's part of the team and to be recognized and warmly greeted. And so when we looked at the Caregiver ID and the experience that has happened across our changing care programs, we know that there are a number of benefits for both caregivers and providers. I really want to underscore that we can't underestimate at this stage of the journey of integrating caregivers into the healthcare system in Ontario, the power of being recognized and valued. Again, that word invisible is something we hear again and again, and the fact that people are being recognized, given a card that actually validates their role, has been incredibly important. So it is, the benefits to caregivers are broader than that, but I think we can't underscore just how important that first step is. So providing recognition to the caregiver role, easing their participation as a team member, so actually giving them the confidence to step forward and ask questions or say something in a meeting that they may not have felt comfortable doing before. It identifies caregivers throughout the organization, so not necessarily just in an appointment, but walking down the hall, you can recognize them much more easily when they have some kind of identification with them. And there can be added benefits, and we're going to hear a lot more about that from Jennifer when she talks about the experience at Sinai House at the BridgePoint site. But there are opportunities to create access, secure access after hours, offer regular check-ins with staff, as we've seen at one of our other sites where they actually hand the card in and out every time they visit a family member, and it gives them that point of contact with the provider every time and creates that regular dialogue. And again, it provides them or gives them the confidence to ask questions which they may not have had before. In terms of the benefits for providers, again, it's an easy way to identify family members. It can increase security. Again, we'll hear a little more about that from Jennifer. It provides that regular check-in also from the provider perspective to understand if there's differences that they're seeing in their loved one from day to day or week to week. And I think the other thing I want to point out here is that although we talk about Caregiver ID as a card, we've also seen one of our Changing Care partners take the identification concept and the philosophy behind it and create their own tool, which is called the Time to Talk Toolkit, which actually facilitates that conversations with caregivers even more. There is an identification component to it, and sometimes that includes a sticker or a badge, but not always. And so there are different ways that organizations can introduce the caregiver recognition and identification program within their organization to meet the unique needs of your local organization. It allows caregivers to play a role at the bedside or on the front lines in a way that maybe they hadn't before. Either they didn't have the confidence to, or the provider didn't know who they should be turning to in the care of their loved one. And it can also be very complementary, as we were talking about today, to a family presence policy or an overall culture of partnering with caregivers. And so when you see the story that Sandi has, that's an organization that's just introduced the family presence policy, but does not have a physical ID card. And yet you hear her talk about what that means to her. So in terms of the work that was done through the working group to develop this ID, there were a number of critical success factors that were identified by the team. So really looking at senior leadership support, family and patient engagement from the outset. So the idea of co-designing this to meet the unique needs of your own organization, provider training and really answering that why question, as we heard Lori talk about on family presence, alignment with other organizational priorities, so in this case, family presence, but other moves towards further caregiver and family engagement. Clarity on what the card functions are. So what is it that you get when you get this card? And again, maybe it is just the identification, but in some cases, like we'll hear shortly, it does allow after hours access to certain areas. Resource referral, and most importantly, when rolling this out, that change management and communication strategies need to be there for successful rollout. There are, when we talk about considerations for implementation, this is sort of a summary of the things I've talked about today. How will you co-design your program with caregivers? Will you include photos on the ID card? Some do, some don't. You'll hear that again from Jennifer in a moment. How will it be distributed? So what's the first point of contact? What makes the most sense in your organization? I think that's different in every single organization. Alignment to other priorities. Do you use a button? What format do you want? Do you offer them a lanyard, a badge? What's going to work in your particular care setting? And then I think the kind of more tricky part is what happens if there is a disagreement in the family of what the caregiver's role is, or whether the patient has a different view of who the caregiver is. And that, again, is a bit of family dynamics that plays out in all sorts of healthcare, and so that needs to be dealt with on a case-by-case basis. And we've actually seen in the case of the implementation of ID in some of our Changing Care projects that they've been able to build in to the EMR whether a caregiver ID has been issued. So that's also something that can be considered. So all of this information that I've talked about today and the tools, the considerations, videos that talk about the importance of the ID program and the impact it can have is all available on our toolkit page on our website. The address is listed there, and we encourage you to explore that section of the website that has some other tools, resources, and checklists that would help you. And as Lori said earlier, we have family presence mentors, and we certainly have caregiver ID mentors that we can connect you with as well if you have questions or want some support in doing so. So without further ado, I will pass it along to Jennifer.
Great, thank you so much, Christa. As it's been mentioned, the Cultivating Change project is in partnership with Wood Green Community Services and Sinai Health System. So Sinai Health System has 2 sites. One's our Mount Sinai Hospital, which is downtown, and then our BridgePoint Health location. So we rolled out the family presence policy at our BridgePoint Health site, which is about a 430-bed hospital, which services rehab and complex continuing care patients. So prior to rolling out family presence and the caregiver ID, we used to have a visiting hours policy. So at 8 p.m., we'd have an announcement saying that visiting hours were over. So family presence was really about removing that barrier and welcoming patients and caregivers 24 hours. Currently, what takes place is there's an overhead announcement that happens at 9 p.m. explaining that quiet hours are in effect. And during quiet hours, we expect everyone to speak in hushed tones, dim lights, and have electronics on low and vibrate. So this includes not only our patients and caregivers, but staff as well. We really want to ensure that having more people able to access being at bedside doesn't mean that we don't allow people to get the rest for the recovery that they need. So when we prepared for rollout, we did a lot of staff engagement. We actually went down to every single unit and had meetings with the staff members. And when we went to the units, we had our Cultivating Change team members, which were made up of some frontline staff, along with security and leadership. And we wanted to ensure that people would know that this is going to be supported by everyone and not just a policy that's rolled out and expected the unit to be able to manage on their own. We had this one-page document that we shared, and this was really about the why, as Lori mentioned. Why are we doing family presence? Why are we having a caregiver ID? And sharing some of the literature was really helpful about how it, it lessens med errors, how it reduces falls, how it helps support patients better, and also for the providers, helps them manage better by getting to know their patients. So we also looked at some of the literature from other organizations who'd rolled out family presence, and they noted there was only a 4% increase in the number of people staying overnight, because one of the concerns were that there'd be a whole bunch more people on the unit, and it'd be really difficult to manage in the evening. And of that increase of 4%, there were hardly any negative incidents that required security presence. One of the concerns that came up, as Lori mentioned as well, is that in the evening, the staff leveling is much smaller than in the daytime. So people were concerned if something happened at night and there's only a few nurses on the unit. They were also concerned about having a lot of people on the unit and perhaps interference with care. So one of the things that we talked about and was kind of a mitigation strategy was having the caregiver ID be linked to access, so that a caregiver could only visit the unit that they were supporting somebody on. So we wouldn't just have, as they feared, a whole bunch of people able to wander throughout the hospital. We also went to the units utilizing unit champions. So they were nurses that we had go to the units and speak to all of the patients and caregivers and staff on the unit. So they went room to room and discussing family presence and the rollout, which took place on June 5th, 2018. And when a patient identified that they'd like to have a caregiver have the ID badge, that champion would gather around as many staff as possible and show them how to enter it in our electronic medical record, so that it was an in-the-moment teaching. And we also wanted to do this, a week prior to rollout, so that we wouldn't have an influx of caregivers waiting to go to security to get their ID badge. We wanted to sign people up ahead of time so that we didn't inconvenience our caregivers. And we also didn't want to make it too onerous on security, which was an excellent partner in this project. After that, we also sent out an alert to all the clinical teams. Just in case someone didn't read the alert in their email, we also did breakfast events. So we wanted to catch people at shift change, especially our nursing, our evening nursing and incoming nursing. So we had breakfast events, and we had a large TV screen that also had our EMR screen with how we'd enter caregiver information, and another opportunity to have those discussions and address any concerns that people had. So we wanted to make sure it wasn't just an information dump that this was happening, but it was actual engagement and discussion about how we could make this possible and how we could make this safe and a positive experience for everyone. You see there's a couple baskets there. We had a caregiver basket and a provider basket as well, just to kind of have, you know, some excitement and draw people over to the booth. So along with all those conversations, we also had this poster outside every patient room throughout the hospital, in the elevators, and in the parking garage. So we really wanted to ensure that no one would say, I didn't know about it or I didn't hear about it, because it was just absolutely everywhere. So prior to rollout, we also went down to the units again with this algorithm, which we discussed, and then we also had them placed on every unit. And what it's talking about is, you know, who needs a caregiver ID badge? So people who need a caregiver ID badge were people who wish to visit past 10 p.m. or before 7 a.m. And some caregivers wanted an ID badge and didn't happen to visit at that time, but they just wanted to know that should something happen or, you know, should their schedule change, that they had the ability to do so, and that's fine as well. So if a caregiver did want to have a badge, what they would do is let staff know, and all the clinical team members have the ability to enter the caregiver information into the electronic medical record. They then go down to security, and security would request a photo ID and match that person's information to what was in the system before issuing the card. So that was another safety feature that helped with some of the anxiety about family presence and opening the hospital up in the evening. You'll notice on the right-hand side, there's a box that talks about, you know, should you need support or have any questions, please contact your unit manager. And then it also states that evenings and weekends, please contact the on-call manager, because we wanted teams not to feel alone in the evening and on weekend. So this is a screenshot of what our electronic medical record looks like. You'll notice there's the 2 caregivers that can be entered into the system. And although we allow 2 caregivers per patient to have the ID card, we ask that 1 caregiver stay overnight at a time. With the exception of palliative care, there's no limits or rules with palliative care visiting. So it asks the first, the last name, and the relationship to the patient. And at the bottom, you'll notice it asks if you're a CCC, a complex continuing care patient, or a rehab patient. And the reason for that is our rehab patients have a discharge date. We have lengths of stay set, so we're able to enter the approximate date someone would be discharged. And that discharge date becomes the expiry for the badge, which again was considered a safety feature, that we wouldn't have badges you know, out in the community and have a large number of active badges when patients aren't actually in the hospital. And then also provided the opportunity to deactivate should any concerns come up. For our complex continuing care patients, we gave everyone a 1-year time, because sometimes people are there for many years, and we always are able to extend that, but we just did that kind of as a rule of thumb. We didn't want people expiring and having to keep on coming downstairs and being, you know, aggravating for our caregivers. These are examples of what the caregiver ID badge looks like. We have 2 badges at the BridgePoint site. The first one is our short-term patients. Because we do have a lot of rehab patients in the hospital, they can be there just a few weeks at a time. So having a photo option for our short stay patients and caregivers would have been quite a process to turn around and create. But for our long-term our caregivers who are supporting someone on a complex continuing care unit, we wanted it to look more like the staff badge, because they're truly a part of a team and are welcome and are with us for quite some time. If a caregiver that is with a CCC patient didn't wish to have their photo, that would be okay as well. They could have the other badge. And you'll notice that there's a unit on the badge as well. All of the floors have a different color, so it was another way to identify where a caregiver would be visiting. So partnering for change, we have 2 quotes here, and one of them is from Nadira, a nurse on the floor, and she says, "I was initially concerned for staff safety and that families might interfere with care. With family presence, caregivers are more involved and share valuable information, which allows me to provide better care." So I really loved Nadira's quote because it speaks to the culture change. She was someone who was uncomfortable with this change in policy, and after it was rolled out and she had the experience with caregivers, she's really a champion of the policy now. Our second quote is from a caregiver, and the gentleman stated that I'll now be able to do some of my own errands, like taking care of myself, and then I can come in without having to ask for permission. So it's just about access, which is great. This is a Better Together dashboard template, and this is what we're using at the BridgePoint site in order to evaluate our family presence policy. It's just been a year now since the rollout of this policy. So what we've done in order to populate this dashboard is we've hosted focus groups with security, our nursing staff, and our patients. And then we phoned 44 caregivers who had access to Caregiver ID badge to ask them about their experience. You'll see kind of on the right-hand side, there's that red, yellow, and green stripe. And this is information that can be pulled directly from our patient and family satisfaction surveys. So some of the things we learned through this process was that socializing the idea is very important. Having those conversations, having people, giving people the opportunity to express their concerns and their feelings, and having that authentic engagement with staff to look for solutions together. We realized that agency staff would also require a badge to enter the hospital. We also recognized that since the elevators didn't move past 10 o'clock, our patients who like to go out in the evening also required a badge. We gave all the units some temporary badges, which we kind of considered a one-time use. And it was really about empowering the unit staff to be able to use their clinical judgment. If a caregiver happened to have stayed, to 11 o'clock one night to support the individual that they helped, we didn't want them to have to go to security to get a badge if they just wanted to go home that night. If they wanted to continue to visit during quiet hours, we would definitely enter the information and have them down. And then also the connecting with on-call managers. The on-call managers always have a binder when they take over that shift. So we made sure we had all of the supportive documentation, that they would be able to answer any questions and make decisions if they were called for support. And then lanyards. We began with just the ID tag with the clips and quickly realized that we were losing cards. Patients have a hard time being able to, sometimes they're driving, a power chair and trying to maneuver a little clip with a tag didn't go well. So we got lanyards, and we chose a bright red lanyard, which was great to recognize caregivers again, and then also to be different from staff, our volunteers, and our students. So phase 2 is really about looking at our PDSA cycles and the feedback we were receiving from staff. And one of the large items was, comfort measures for our caregivers. So we ordered more recliner chairs, and we also put asset tags on them. So it's the same asset, it's the same as our wandering system for our patients. So we're able to know where the chairs are at any time, so we can find one to support a caregiver. We created frequently asked questions documents, both for providers and for caregivers. And then we had to explore dining options because our cafeteria closes quite early. So we created a document of all the options for dining within walking distance, as well as who will deliver to the hospital to support our caregivers in the evening. And then we co-designed an expectations document, which was all about what caregivers can expect from providers and also what we ask of our caregivers. And then we continue to do ongoing PDSA cycles. I'm going to turn it back to Lori for questions.
Okay, so we do have a couple of questions coming in on the chat line. And I encourage people to continue to send those in. The first question is, some hospitals are currently trialing or have implemented visitor ID badges. Was there discussion with how this program could mirror or support that initiative? And if so, was there anything to distinguish a visitor badge from a caregiver badge? So maybe both Christa and Jennifer could speak to that.
Okay, so we have not trialed this in an organization that has a visitor ID badge in that way, and it did not come up in our conversations in terms of distinguishing the two, but ultimately they can be very complementary. So having the purpose of a visitor badge to identify and having the purpose of the caregiver badge to also identify, but also make them part of the team, I think is the added component. And so we haven't trialed it anywhere yet. It's only in our 2 organizations. So the Sinai BridgePoint site and the Cornwall Community Mental Health organization building.
Mm-hmm. And I was just going to mention that we don't have we've never had a visitor, any kind of identification. So having the caregiver ID badge was the first time that we recognized our caregivers in the hospital. We don't have an emergency at the BridgePoint site, and I know that some organizations that have emergencies have used the visitor kind of stickers.
Okay, a second question is very specific. Who puts the name of the caregiver in Meditech?
It's a great question. I'm glad someone asked. Anyone who has clinical access, so any nursing, any of the health disciplines, they're all able to enter the caregiver information into Meditech. Oh, here's a new question. Okay, oh, we just lost it, sorry. Can you speak to how you mitigated space constraints? Hospitals often have small rooms which are shared and may not have room for recliners for caregivers who stay overnight. Yeah, so we're really fortunate at the BridgePoint site as we moved into a brand new building 5 years ago. And with the new building, there's only private rooms or semi-private rooms, and they're quite large. So we're actually able to accommodate the recliners. On our palliative care unit, there's only single rooms. So again, there's not a sharing for there. And a lot of our caregivers that do stay overnight tend to be with our palliative care patients. Thank you, Jennifer. We have a follow-up question. Have you trialed this in a facility which does not utilize access control readers or 24/7 access control office for production of badges?
So the question, the clarification on that is just the difference between the BridgePoint experience and the Cornwall experience. So in Cornwall, it doesn't provide any kind of access. It is actually given to the caregiver when they come onto the secure unit, and before they leave the secure unit, they hand it back in to the provider. And as I said, that creates the opportunity for an ongoing dialogue. And so the badges are mass produced and they don't have photos or names on them. And so they're actually just used generically by each caregiver who comes in. But it means that while they're on the unit, staff can walk through the unit and easily identify who the caregivers are.
Did you want to add anything, Jennifer?
I just wanted to add that at the BridgePoint site, all the access, the card is the access. So everyone that has the ID card will have access attached to it. But we're currently reviewing the Sinai site, our other hospital in Sinai Health System, and really meeting with all the different departments to understand their needs, because it won't mirror the BridgePoint site, because there's the emergency department, and currently in our neonatal intensive care unit, parents caregivers get in by fingerprint. So there's a lot of different things to consider, and what populations you're serving and what's currently taking place.
Okay. Another question, is there any type of compliance or monitoring to ensure that information about caregivers is entered into Meditech?
So the information entered into Meditech is the only way the caregiver can actually obtain the ID card, because what happens is security accesses that information and then verifies it with a photo ID before giving the card. So we haven't had any difficulty. We haven't had anyone that we know of like sharing their card or anything like that. There's been no negative reports.
Okay. Is there any connection, collaboration, or communication of this initiative to the long-term care system?
Great question. Not yet. I mean, yours is not long-term care, obviously, but you do have longer stay patients. And I know that that's true in the pediatric, like Holland Bloorview has a similar model. They use a family visitor badge for their longer term as well. So you could talk maybe about the difference between the two, because you offer a photo for longer term as well.
That's correct. So for our longer stay caregivers that are supporting someone who's complex continuing care, so sometimes that's someone who's at the hospital due to dialysis needs, or sometimes they're just so medically complex they can't be managed elsewhere. So we have the differentiation of the photo for the caregivers, and then we have the access on the card.
And, you know, I think in our view, there's opportunity for this in the long-term care system, and we could certainly make that outreach and connection, and are more than willing to share our experience to facilitate any introduction of it in any LTC facility.
Okay, there's a new question. Can you give examples of education or training staff received on how to manage challenges?
So we, at the BridgePoint site as well, and as well as the Sinai site, recently went through Service with Heart. And so that's offered from the Cleveland Clinic, and it's all about how to have positive interactions. And it's also about relationship recovery. If something doesn't go well and someone's upset, how do we, you know, take the steps to get to a solution together and to resolve any concerns. So all staff had the opportunity to go through that training, which is just a great tool to help them when you get into a situation and that you want to, you know, diffuse and find a positive resolution together, as well as ensuring that staff don't feel alone. We really brought security to many of the meetings in order to say they're here. They are always here. They're here 24 hours a day, 7 days a week. And if you need any support, don't be afraid to phone and ask for it.
Yeah. At the Cornwall site, they had a very similar process where there was a central place to go if any providers were having any challenges in the early days of implementation, and to today they can call to get support and how to deal with that.
Okay, a new question. Other than comfort measures, have there been other kinds of support requests from caregivers that have come up in the rollout, and things that they would feel would be helpful to their time supporting their family member in the hospital?
Yeah, so through the Cultivating Change work, family presence and caregiver ID was kind of one component, but many of our change ideas have been around peer-to-peer support opportunities as well as formal support groups. And we're currently also, we've just sent out our request for quotes for our caregiver resource space. So there's a lot of other initiatives taking place at the hospital that will help with education, training, and support for caregivers.
And I would just add from the Change Foundation's perspective, we have a lot of information about other things that would be helpful to caregivers in both in hospital, but also writ large. On our website, I would point you specifically to the wish list that's available on our website, which is very specific examples of things that would be helpful, as well as the Spotlight report, which outlines some of the challenges and needs of caregivers as well that you can review as a resource for that.
I would also add that with the Embrace Changing Care project in Cornwall, one of their key initiatives is the Caregiver Resource Center, which they are currently developing.
I just actually wanted to add one more thing as well, and it's just about after rollout, and when we did the focus group with our evening shift nursing and asked how things were going and any concerns that they had, you know, what we heard back is that people had fears about a lot of people staying overnight, but what they found is that usually for our rehab unit, it's about the transition. So when a patient first comes to the hospital and it's a new environment, often a caregiver might stay over for a couple nights to help them get settled and make sure they're feeling, you know, secure and they're not anxious about being in the new setting. And then for our CCC patients, you know, people often stay over at different times, especially if someone happens to, you know, spike a fever or feel unwell. So after the rollout, and people were initially nervous, it really calmed down a lot, and people have implemented the policy and been really pleased about it.
Okay, another question. What training would you suggest to give staff in how to have appropriate conversations at removing visitors from the patient room? And they give an example. We have run into some difficult situations where a patient has a loved one who staff feel is intoxicated and disruptive, but the staff feel uncomfortable and unsupported to ask the visitor to leave.
That's a great question, and that was actually one of the concerns as well before rolling out, is what would we do in that situation? And in that situation, we said to the teams, you know, what do we do now when it's the daytime and we have an individual who's intoxicated? So it's really about looking at the policies that we already have in place, and it wasn't a change due to family presence, but when it comes up, following what the hospital's already outlined as our policy.
Okay. What if you can't share with other family members?
I know. So my interpretation is, what if you can't share the card with other family members or lose or forget it at home?
Yeah. So the units all have the temporary badges. So if that happened, if someone happened to have forgotten their badge, the staff that was working that evening could use their clinical judgment to loan a card. If someone loses a card, they can just go to security and get a new one. And security can look them up and deactivate the card that's been lost and then give them a new card. We have no charge for our caregiver ID cards. We didn't want there to be any kind of a barrier to someone accessing a card.
Okay, I think we have time for, we've got one last question here. I come from a family of 5. We would all be in at different times as caregivers. How do you support 4 caregivers providing care? Would you provide 4 badges?
We would. So what would happen in that case is we would just speak to the unit manager, and the family would let the unit manager know that everyone would like to have a card and be visiting at different times, and we would accommodate.
Okay, I think that's all the questions for now. We're running out of time. I just wanted to highlight, if you have any additional questions, we're happy to answer those offline. I'd also encourage you to get in touch with us. The email address is at the bottom of this slide. If you're looking for more information or you have questions about the research project on family presence, certainly get in touch. If you're interested in implementing Caregiver ID in your organization, get in touch. Or if you're considering implementing family presence policy, but you'd like us to put you in touch with an organization who has experience with family presence, we would be happy to do that. So please use that email address at the bottom of the slide, and we'd be more than happy to respond to any of those requests. So at this point, I'd like to say thank you, everybody, for participating in the webinar, and we look forward to hearing from you if you have any questions or follow-up queries. Thank you.